So with that, I'm going to go ahead and introduce tonight's speakers. Our first speaker tonight is Jessica Burns, palliative care nurse practitioner. Jessica, she joined Archbold in 2012, where she began her career as a critical care nurse in the ICU and recently transitioned into the role of palliative care nurse practitioner in 2017. She earned a Bachelor of Science degree in nursing from Thomas University and a Master of Science degree in nursing from Florida A&M University. She is practicing inpatient and outpatient palliative care here at Archbold. Our second speaker is Sheri Walters, administrator at Hospice of Southwest Georgia, which is a not-for-profit hospice agency based in Thomasville. Sheri joined Hospice of Southwest Georgia in 2010 as clinical manager and became administrator in 2015. She earned an Associate of Science degree in nursing from Central Florida Community College and a Bachelor of Science degree in nursing from Grand Canyon University in Phoenix, Arizona. And rounding out tonight's program is Archbold's Foundation President, Vann Middleton. Vann graduated from Vanderbilt University with a Bachelor of Arts degree in history and a Bachelor of Business Administration from Vanderbilt's Owen Graduate School of Management. He joined Archbold in 2013 after a 12-year career with Tall Timbers Research Station and Land Conservancy in Tallahassee. He leads the foundation, which is an independent, not-for-profit charitable organization that supports programs, services, and capital expansion projects for the health system. Vann will conclude our program with information about Archbold's new inpatient hospice center. And with that, please help me welcome our speakers.
Hey guys, how you doing tonight? I'm Jessica Burns. I'm the palliative care nurse practitioner here at the hospital. So I'll kind of start out with what is palliative care. A lot of people get these things confused. Hospice and palliative care, are they the same thing? What's the difference? So tonight we're going to kind of help explain what they are and what the difference is. So palliative care is a specialized medical care for people with serious illness. Any chronic illnesses that cause symptom burden on the body can be managed by a palliative care provider. So this type of care is focused on providing a relief of symptoms and the stress of a serious illness. So the goal is to improve quality of life overall for just both the patients and the family. So our most important thing that we do is making sure quality of life is the best quality that it can be and helping manage those symptoms so that you can have that great quality of life. So the main philosophy in palliative care, it centers on a team approach that includes both the patient and the family. So it's very important that we get everyone involved and not just the patient having to go through things themselves, because living with chronic illnesses is a hard thing to do. There's a lot of things that you have to do, lots of medications you have to take, doctor's appointments. So getting your family involved or friends, just anybody that can be that support for you, making sure that you have them involved is what we like to kind of include in that team approach. So the palliative care team works in partnership with your own doctor to provide that extra layer of support for you and your family. We provide symptom management. We help with extra time for communication about kind of your goals of care and kind of what your treatment options are. And we also help navigate through the health system. So, not only are you seeing a palliative care provider as a specialist, but we work very closely with your other specialists that you see. So your primary care physician, if you have a cardiologist or a pulmonologist, we kind of help work as that middleman to pull everything together and to work on your whole health care all in one. So palliative care is not hospice, but hospice is always palliative care. And this can be confusing. I understand even reading it confuses me a little bit, but the main thing that you guys can understand is palliative care is the symptom management. So in hospice, their main goal is making sure your symptoms are managed as well and providing comfort to the patient. But what's different is that hospice is for people with less than 6 months of life or less. And Sheri will touch more on that in just a minute. But so the main difference is then when you're looking at that is that symptom management and palliative care is done alongside curative treatment. So it's available at any age, any stage of an illness. Anyone with that chronic illness that needs that symptom management, it's provided alongside curative treatment. So you can continue to see your other providers and your physicians. For example, if you have cancer and you're still receiving chemotherapy or radiation and you want that extra help of support for, say, nausea or pain, some symptoms that come alongside of that, palliative care can be done with that and managed because it can be provided along with those curative treatments. Let's see. So you don't have to be at the end of life to receive palliative care, and you're able to continue to see those specialists and other providers. Palliative care is kind of it's great for those patients who aren't quite ready for hospice. They're still seeking that curative treatment, but they really have that crucial symptom management that needs to be taken care of. And so that's something that we can help with, is making sure that that symptom burden can be managed, and you can still continue to seek the treatment that you'd like. Okay, so some of the types of illnesses or disease that we see in palliative care are patients with metastatic or recurrent cancers, anyone with an advanced COPD, end-stage renal disease, heart failure, stroke with decreased function, end-stage dementia patients. We also work with neuromuscular diseases, so patients that have Parkinson's disease or ALS, things that need symptom management. And then any moderate to advanced concomitant disease, so that would be, say you have an advanced stage COPD, but you also have a mild diagnosis of heart failure. So you've got this other disease that can be causing a burden on something else as well. So you need kind of dual symptom management. So we work along with those types of patients as well. So the interventions that are provided by palliative care, here in the hospital, I round on patients that have all these serious illnesses, and we kind of focus on several topics, but one of the main things we do is symptom management. So really the goal of that is kind of trying to increase quality of life by decreasing that symptom burden. So helping patients manage those symptoms, whether that be pain, anxiety, appetite, sleep, issues with sleep, really anything that's just going to cause that burden on your body and help you, cause you to be uncomfortable. We manage those symptoms. We also work closely with goals of care conversations. So I don't know if any of you have ever talked with your primary care providers about your goals of care, but this is something that's extremely important and that I recommend you do at your next appointment if you haven't ever done it before. Especially if you have a chronic illness that needs some extra support and management. Really, goals of care is kind of talking about, what is your understanding of your diagnosis? What are your fears and worries? What kind of things are you willing to go through in order to continue curative treatments or seek more, more time? Those are important conversations that we don't often have until we get to a critical moment when it's really hard to have those conversations. So that's something that's very important, and I recommend you guys do once you leave here today. We also go through complex medical decision-making discussions. So that's kind of a mouthful, but what we do is, say there's a patient who has a new diagnosis. They're not quite sure where to go, what this diagnosis means, what their life can look like past this. So I kind of help have those conversations with patients and families to explain what they can expect, what treatments are going to look like, what medications they can take, and some side effects that can happen with those. So having those important conversations. We do life-sustaining decision discussions and advanced care planning. So talking about, if in the event your heart were to stop and you were unable to breathe for yourself and you'd have to be placed on a ventilator, what would that look like? Is that something that you would want done? Helping fill out advanced directives, that's very important that everybody has one of those. It doesn't matter what your age is. Really, everybody should have one, because in the event that you're unable to make a decision for yourself, having that directive written out, it makes it so much easier on your family to make those decisions because they know it's exactly what you wished. We also do some medication recommendations in the hospital. So if patients have nausea or pain, I can help with recommending medications if something's not working, trying to find that right dose for them. We also do code status discussions, so talking about being a full code, a DNR, a DNI, all of those words that can get confusing in a hospital setting. But if you have chronic illness or several chronic illnesses, and everybody's decision is different based off of whether they would like to be resuscitated or not and how that works. And so it's important that you talk with your provider and kind of understand what that means and how that would change and what would go from there. We also focus on patient and family support. So this is a big thing. We kind of focus on your whole biopsychosocial and spiritual care. It's whole body care. It's not just your disease being managed, it's what your spiritual wishes are and your emotional distress that you're going through. When you have a chronic illness, it's more than just living with a diagnosis. It causes a lot of burden in a lot of places, a lot of trouble with family and, making sure you can still live and do the things that you want to do. So having that extra support, whether that's provided by the provider, by social workers and case managers, by chaplains, it takes a whole team approach to really get you what you need. So we try to make sure that we have all of that together for you. And then lastly, we help with hospice introduction and transition. So if we get to a place to where curative treatment is no longer something that we're able to move along with, then I can kind of help get through that decision and then help transition you guys to hospice care. And the wonderful providers that we have here with Archbold's Hospice, there are so many people that can help you with whatever you need. And they're such a good support for you and your family to help during that difficult decision. Okay, so does palliative care mean that the doctor's given up and there's no more time left? No, that's what a lot of people think. As soon as they hear, oh no, they've consulted palliative care, this is awful, it's the end of everything, what are we doing? Do not think that. Palliative care is ensuring that you can have the best quality of life to live with your diagnosis and the illness that you have. So really the only thing that's changing is that our goal is shifting to living a life as full as possible by managing those symptoms so you can have a better quality of life and do the things that you want to do and not be stuck in a hospital having to have your symptoms managed that way. Let's see. So after hearing kind of what palliative care is, do you think that you could benefit from palliative care? Anybody with chronic illnesses that have a symptom that they take medication for, if they have anxiety, they take medication for anxiety. If they take medication for pain, if they have issues with breathing, if they have COPD, those are all things that can be managed with a palliative care provider. So we provide care for patients both inside the hospital and outside. So we're just starting our outpatient clinic. I'll be seeing patients actually at the oncology center. You don't have to be an oncology patient in order to receive palliative care, so don't be deterred by that. But really, we'd love to help manage whatever we can. People that have chronic illnesses are often readmitted into the hospital over and over and over, and it's really mainly for a symptom that needs to be managed. So what we're trying to do is provide, the people in our community that extra layer of support that they need to get their symptoms managed so they're not having to go to the hospital and continue to go back and forth. Main thing I want to kind of touch on too is making sure that you start palliative care early. So a lot of times people get diagnosed with a chronic illness and they live with it until they're at an end stage of that chronic illness, and then they start seeking what palliative care is. But really, palliative care should be initiated at diagnosis, because really, if you've never had a chronic illness before or you're living with this new diagnosis, you're not really sure what to expect or what to do, and that's something that we can help kind of talk you through and learn to live with. Starting palliative care early in a course of illness can ensure that care is more in line with the patient's wishes. It can decrease stress and increase confidence in making decisions surrounding the patient and the family's loved one's care. And it also can meet emotional and spiritual needs of the patient and their families. So there's a lot of things that we can do to kind of help you and your loved ones out, and we'd love to be able to do that. So the only thing that you'll need is a physician referral or consult. So the way that works in a hospital setting, say your loved one's in the hospital and you think, I think they need a little extra support and maybe they could benefit from palliative care, just ask the provider. You can ask the nurses, and the nurses can talk with the doctors and let them know that the family's interested in palliative care, and they'll call me and I'll come down and check out and introduce myself to you guys, and we're happy to help however we can. How it would work to see me on an outpatient basis is just talk with one of your providers. Whatever your chronic illness is that you're living with, whether that's you're seeing a specialist for it or it's your primary care doctor, just talk to them about it and say, you know, I think I might be able to benefit from this. They can give you some more information and they can put in a consult for me. I'd be happy to set up an appointment. Even if it's just to sit down and talk about, you know, kind of what your goals of care are. Even if you don't have a symptom that's, you know, not managed at the time, it doesn't have to be that. It can be just to kind of sit down and figure out what your goals are, what your wishes are for your next step in your disease process. So we're happy to help with that. And on that note, it's up to hospice. So thank you.
All right. Everyone, just so you have a little bit of information about me, my name is Sheri Walters, and I am the administrator for Hospice of Southwest Georgia. I joined Archbold in 2010 as a clinical manager, and my experience is, I hate to say this, but 30 years, I actually added it up, I've been 30 years in the hospice field of nursing. This is the 4th hospice that I have been privileged to work for. We have an excellent group of people that work with me, and I'm going to ask my folks that are here to stand up for just a minute. Y'all stand up. There we go. This are a few of the staff. We have there we go. Thank you very much, everybody. Appreciate that. This hospice started in 1989, so we are in almost our 30th year at Archbold. So I just wanted to tell you a little bit about hospice, and really it's hospice in general. It's not specific to Hospice of Southwest Georgia. But as most of you all know, hospice focuses on patients that have a life-limiting illness. I didn't put it up here, but it generally is 6 months or less to live. The 6-month or less timeline actually came from Medicare, and we do have patients that live longer than 6 months. At the 6-month mark, our medical director, who is Dr. Jason Griffin, he makes a visit to the patient's home, and he evaluates to make sure the patient meets the criteria to stay on hospice. So we don't kick anybody off if they've lived to that 6-month mark. And a lot of times it's because of the good care that they're getting with our clinicians that they've made it to the 6-month and 8-month marks and things like that. So the sooner we get people on hospice, the better for them as well. Our focus is for comfort and quality of life. So when we get a referral can come from anybody. It can be from a family member, a neighbor, a physician. We always have to have the physician's permission to serve the patient, but we can talk to anybody. So we wait to hear from them, and then we'll make an appointment, come out and talk to them about hospice. We have a team approach. So we have, and I think on another slide I actually talk more about the team, but we have experts in medical care, pain management, emotional support, spiritual support. Our chaplain is here today. So our philosophy is to help patients die pain-free, at home, surrounded, and supported by their family. So that's our ultimate goal. Okay, where's that? There we go. Okay. So our primary place that we serve patients is in their home, although if they call an assisted living or a personal care home or a nursing home, we serve them also in the counties that we serve. We serve patients regardless of their age, religion, race, illness. We do take care of children from time to time. We recently did have a baby, an infant. It's rare and it's hard for us, just like everybody else. But the way hospice services are covered is through Medicare, Medicaid, and most private insurances also. We do, though, however, provide care to patients regardless of their ability to pay. So if somebody has no insurance, they get the same care that everybody else gets. Our nurses and our social workers, chaplains, they all get the patients get regular visits. The nurse sets up how often a visit's needed. It might be twice a week. It might increase as the patient declines. We do have a nurse on call 24 hours a day, 7 days a week, so we are always accessible. This is a cute little, I didn't do this, it's really cute though. We have an interdisciplinary team approach, so every Wednesday we get together with our medical director, Dr. Griffin, and we review all of our patient care issues that are going on. He gives us guidance. All the disciplines are there, the chaplain, social workers, the home health aides, everybody has input to the patient's care. This is Roger. He's one of our registered nurses. And I don't know if anybody knows Roger, but he's fantastic. Our team consists of the patient's personal physician, our medical director, registered nurses. We do also use LPNs as well. Home health aides, social workers, spiritual counselors, trained volunteers, and if needed, we use speech, physical, and occupational therapy. Our main goals, the role for the hospice care team is to manage the patient's pain and symptoms, to assist the patient and family with emotional, psychosocial, and spiritual aspects of dying. This may be the first time for a lot of people, and for us, that's what we do every day. So we're there to support them. We provide any medications related to the patient's disease or comfort, anything for pain, nausea, anxiety, anything that we can kind of relate back to the reason that we're taking care of them, we do provide. Any medical supplies, equipment, oxygen, hospital bed, anything like that. And our role is to educate the family. The family's the one that's there doing the heavy lifting and the care. So it's our role to teach them and to educate them how to do the best job they can, the caregivers. We provide the speech and physical therapy as needed. We also do short-term inpatient care. We have contracts with all of our Archbold hospitals. So if a patient has an uncontrolled symptom like pain or nausea, we can put them in the hospital for a short period of time to get their symptoms under control, and then they usually go back home at that point. Also for respite, if a caregiver needs a little break, we can put them in for 5 days just to give them a little break. And we do follow our patients' families for 13 months afterwards, support and care afterwards. Oh, that's it. Wow. Okay. All right. Thank you.
Okay, well, you just heard from two of the most clinical rock stars that we have here at Archbold, and now you're about to hear from the most non-clinical person employed at Archbold. And as Ashley mentioned earlier, my name is Vann Middleton, and I'm the president of the Archbold Foundation. And I'm real excited to talk a little bit today about an option that we are bringing to our community here in Thomasville that we've not had. That has really been on the drawing boards for quite a long time, and I'll talk a little bit about it, and that's bringing inpatient hospice to our hospital here. This picture here is of the west wing of the hospital that fronts Gordon Avenue. And when I was a child growing up in Atlanta, my grandmother lived on Archbold Avenue, right behind Dr. Beverly and Brewer's house, their offices. The house is no longer there. But I do remember in the 70s, Dr. Maxwell, would that be about right, mid-70s, when they were adding the 5th and 6th floor to that west wing. So what we were looking at is bringing an inpatient hospice experience or hospice house experience to the Thomasville area. And Hospice of Southwest Georgia, as Sheri said, has been doing this in an outpatient way for 30 years, at home or in a nursing home, sometimes here in the hospital. But the nearest inpatient hospice opportunities are in Albany, the Wilson Hospice House, which is 65 miles from Thomasville, or in Valdosta, which is the Langdale Hospice House, about 50 to 55 miles from here. And all of them are outside of this 30-mile radius that most hospice folks will tell you that's about the range that family members feel comfortable in having an inpatient setting. So they're constrained to Thomas County, Brooks County, a little bit up to Colquitt County, maybe Seminole County, and certainly over in Grady County. And we wanted to not make a mistake that these two examples, Langdale and Wilson, while not knocking them at all, they are freestanding hospice houses, but they were a little bit overbuilt for what the true market demand is. The Langdale Hospice House has 24 beds. The Wilson Hospice House has 18 beds, and they're both wonderful facilities, but whether they have one patient there or they have 24 patients there, they have to be staffed appropriately. So, as I mentioned, there's a long history of discussion about an inpatient unit, and it goes really all the way back to, like Sheri said, 1989, when the Lewis Hall Singletary Oncology Center first opened, the first oncology center, which is now where some of our physician offices are across from the emergency room. And then in 2014, it was actually put in the master facility plan. It was part of, okay, here's what our long-range goals are from a capital needs standpoint are, but kind of put on the back burner because we had these big projects. The East Tower, where we're sitting right here, in 2004. The North Tower, which is the newest patient care facility, and of course the new Lewis Oncology Center across the street. That was about a $225 million investment over the course of about 15 years. So in 2016, when the Archbold Foundation kind of got involved with health services, Clay Campbell asked if he could apply for a grant. That's one of the things that we do. Besides raising money, we also distribute money to entities within the hospital and health services. And so he hired Jay Cushman, who is a consultant from Oregon, I believe, who all he does is look at market studies and look at needs assessments in communities related to hospice. And he did a very careful analysis of the market demand here, of which Hospice of Southwest Georgia clearly has the dominant market share on the outpatient side. And his sage advice was, don't do like Field of Dreams and build it and they will come. You need to do a real careful analysis of what you're going to build and how they're going to be there, how they'll come. So we had two options that were presented: a freestanding hospice house, like they have in Albany, like they have in Valdosta. Some of you may be familiar with Big Ben Hospice down in Tallahassee. And they looked at an 8-bedroom, $12 to $15 million cost for a freestanding unit. And this particular hospice house of the Piedmont, that's in Greenwood, South Carolina. Or repurposing a floor in existing space within the hospital and looking at a 4 to 6 bed unit with common areas, living areas for family and friends. And this example here is at Emory Midtown in Atlanta, where they used their old maternity floor and turned it into, and I've been to visit, it looks like you're walking into the Ritz-Carlton. It's far away from all of the patient care areas, and you feel like you're really in a homey setting, and almost like a hotel. So in 2017, last year, the foundation provided another grant, a second grant for some preliminary architectural drawings, and they hired Isla Burdett out of Atlanta. Isla is very well known for most hospice houses and units that are built in the Southeast. And she was charged with repurposing that older hospital wing and make it look warm and inviting, more like a family home environment. And to keep it kind of away from all of our patient care rooms, so that you feel like you're really, although you are a part of the hospital, the North Tower is way over here, and the East Tower is where we are right now, and the West Wing, as you might know, is a good ways away from here. So almost make it feel like it's you're coming to a hotel. So we decided to kind of follow that Emory model, and the board of directors looked at various things, and what Isla Burdett shows, and I know this is probably a little bit of confusing to you, but I promise you it'll make it look a little bit better here, was we proposed to put it on the 4th floor of the West Wing. Right now that is currently vacant space. The West Wing, or the west side of the West Wing, which is going towards downtown, would be used for staffing and future expansion if indeed this was something that were to grow in our market. And then the east side that goes down Gordon Avenue towards Thomas Drugs and further down, that would be for patient care rooms and family living areas. So the current, if you walked up on the 4th floor right now, you would see that there are 14 smaller patient care rooms. There's a solarium there at the end of the At the end of the hall, it's a waiting room, and then there are 2 little offices for nurse managers in its current space. Now, again, it's vacant right now. There is one larger patient care room. If you look at the bottom right down there, that was one larger room that was reserved or used for certain cases. What Isla Burdette did was taking that current scheme and instead of the 14 rooms, make it into 6 larger patient care rooms and double the size of what they currently are. We're plenty of room for overnight guest sleeping. There would be common family living area space in between the patient care rooms, and that the sunroom in the back would have a family kitchen area and a quiet room or a chapel for reflection and to bring in your chaplain to talk. And then there would certainly also be a large central bathing area for special needs as well. So this is the drawings that she's come up with. If you popped off the elevator and you went to the West Wing elevators, which are on the far opposite side of the hospital, and you took it up to the 4th floor, the elevators would open up directly into what we're calling the resource center. And this would be staffed by hospice volunteers. It would give you all the information you would need about the inpatient unit itself. And I should back up because Sheri would be upset if I told you that this is not going to be for everybody. This will be for a small fraction of our hospice patients. These are the patients that might not have the ability to have a caregiver at home, or may not, in their final end-of-life care, want to die at home, and families that might want to have them in this type of a unit. And that's, like I said, a small percentage. That's why we're only looking at 6 rooms. Then you would turn the corner and look at the reception area as you head towards the patient wing, and this is another little reception area with a nurse's station. You can see those floor-to-ceiling windows that look out over Gordon Avenue, and if you pay careful attention to that area, you have these beautiful live oak trees that go all the way up, and so you kind of feel like you're up in the trees there. And that little glassed-in area off to the right is a place for kids, for children and grandchildren. We'll have TVs and probably have an Xbox or some games and things for them to have there. And then this is a view of the family living room between 2 patient care rooms. So it's an opportunity for you as a family to maybe walk out of the room, have discussions. You can see there's a couch, there's a little sitting area. If your loved one might be sleeping and might want you out of the room, you can go and hang out in the family living common areas. And again, you can see the windows up in the trees there with the oak trees. And then here is an example of the patient care room. Very large and roomy, looking out over those trees. Very non-clinical room. You don't see any hoses. You don't see any oxygen. You don't see anything that you would see in a normal setting in the hospital. All of that's hidden behind the headboard there. It's made to look like your home. It's made to look like a very warm and comfortable place. There's plenty of room for all your photographs and personal effects that you would want to bring. And so, again, it is made, we're managing their comfort, as Sheri says here, managing their pain. We also want to manage their mood as well, and the mood of their families as they're here, and friends, of course. And then at the end of the hall, there's this bright and airy space, the solarium, as we call it now, that really, truly is looking out over those oak trees. And it kind of creates that peaceful setting. We want to make it look very Thomasville or South Georgia, so the decor will look very much fitting with our community. And then on either side of that solarium, there is the quiet room, the chapel, off one end. And then on the other side is a family kitchen area, and that's off the opposite side of that quiet area. And it's dedicated for eating and light fare for the families and their friends. So the medical center board of trustees, after we gave both of these grants to hospice or to health services, the first one was the needs assessment, the second one was architectural drawings. The medical center board and Perry Mushton said, okay, now you got to raise all the money, because we feel extremely are very strong that the community will support something like this. And we know from many stories, and as the president of the foundation, we get lots and lots of donations in memory or in honor of families that have gone through hospice. And we know it resonates with people. And so we felt like, and as I told Perry, I felt like this is something that we could bring to the community. So in about this time last year, the Board of Trustees gave us the green light to start talking about this in a quiet phase within the community. Now, you haven't heard about it yet because we wanted to make sure we would be successful in the early stages before we really started talking about it in the public. So the build out of that fourth floor was estimated around $3 million of furnishings and equipment, another $1 million. And then we're looking to create an operating endowment of $2 million that would help yield a little bit of revenue and cover any shortfalls in the first few years of operations. So it's a total of a $6 million project. So they gave us the green light in October of 2017. We said, let's take 12 months to go talk to some of our big donors, potential big donors, talk to them about the project, and then we'll enter that public phase of the campaign once we secured 80% of the overall goal. So the goal now for the next 6 months is to roll this out publicly, speaking to folks like you. We'll be speaking with our staff here at the hospital about their potential to be able to be involved, and of course our employees and physicians, and we look for about a 6-month campaign there. But we want to provide everyone with the opportunity to make a gift to this hospice in memory or in honor of a loved one. So where are we right now? We have secured $4.5 million in cash and pledges. The lead gift was made in memory of Johnny White. Some of you may know Mr. White. He was a wonderful businessman in Cairo, a longtime trustee of the Archbold Hospital. He was the founder, one of the co-founders of the Archbold Classic Golf Tournament, which this year was held last week, and we raised $250,000 to go specifically to this project. So I really need to update that we're really at $4.75 million. And so his wife, Beth White, and her family gave the lead gift, and so the hospice unit will be called the John B. and Elizabeth B. White Hospice. It shouldn't say Palliative Care Center, it should just say Hospice Center. We have made an additional private appeals of around $1 million that we'll hear from here within the next 2 to 3 months. And we're beginning this public phase right now with hopes of construction in the current fiscal year, which started October 1. Now there's quite a lot of permitting, engineering, as you can imagine, to get us to a point where we can actually start to break ground. But we hope our completion and our target date is 2019-2020 fiscal year, about a year from now. How can you get involved? Question I like to always ask. You can contact me at the Archbold Foundation. That's my phone number. That's my direct number there. You can go online. We are going to have a donor wall specific to the Inpatient Hospice Center, and all gifts or donations and pledges of $1,000 or more will have recognition on that donor wall. We plan to have an art off the wall in 2019, similar to what we did at the North Tower, so we can provide local artists and photographers a way to really dress up the building. And for those of you interested, I brought plenty of these brochures that talk in great detail about what we're doing. There's some great testimonials from family of those who have used hospice. And that's probably the number one thing that I get as when I talk about this with folks is my mom, my grandmother, my grandfather used hospice, and it was those nurses, those volunteers, those chaplains, those administrators that really touched my lives. And it's something that's hard to explain unless you've experienced it. I did have to experience it with my grandmother in the late 80s, and it is something very special. These folks that work for hospice and palliative care are special, special people. Or you can become volunteer, right? We always can use volunteers with hospice. So I will end it by saying we are well on our way to reaching that $6 million goal. We are very excited about talking about this publicly, and look forward to joining these two very smart ladies and hopefully answering a few questions if you have any. Ashley, is that how you want to handle it? Okay. Thank you all for being here tonight.
You guys have any questions?
Timeline.
For the inpatient hospice center?
Okay, so right now, like I said, we are in kind of engineering, getting more final documents. We needed to make sure that we were underneath the certificate of need threshold, which is big in the state of Georgia. Georgia is a CON state, so we have rectified that. Once all of that permitting comes along, I believe we'll be breaking ground about mid-year this year, with hopes of around this time, they say about an 8-month to 9-month window. So let's think about January of 2020 as
Thank you.
and
I don't know if this is all right. I am 100% confident that we will raise well over than that $6 million goal. The response that we've gotten from the first 12 months, or not even 12 months really, of talking with potential donors has blown my mind. And like I said, last week we got another $500,000 gift that was, I don't know if it was a surprise. It was a surprise that it was more than what we asked for. That rarely happens. So.
Anyone else?
Were you saying that you've gone with the 6-room plan instead of 14?
Yes, ma'am. So it was originally, the floor had 14 patient care rooms, smaller, that probably would not meet ADA compliance right now, I would think. And there are lots of hospice regulations that I don't have a clue that this young lady can tell you more about. So what we determined was our market could support a 4 to 8 bed unit being at 80%, 60% occupancy on a regular basis. So we landed on the 6 number, and it fit perfectly.
Is there a definite plan for educating the community, beginning with the medical community,
About the inpatient?
about palliative care and about hospice? Just letting them know what it is, and no, you don't go there one day and die the next.
Right, well, and do y'all want to speak on that, about how y'all have educated the medical community?
So I know for palliative care specifically, I do education and orientation for all of our new nurses. I work with our critical care nurses very closely as well, just educating on what palliative care is in general and what we can help with. So we've started with staff education with that here at the hospital. We do actually, what are the Rotary meetings and things like that. We've tried to do talks with those. You know, really just, that's what this is for tonight, is trying to get out to the community to help people understand what it really is and what we have to offer. Same with hospice, is just providing that education for people. When the patients come in the hospital, families have questions, really just sitting down and giving them the time to answer questions. Because I know a lot of people have hesitations thinking exactly what you said, that, you know, if I'm going to go on hospice, that means I die tomorrow, you know, and explaining that that's not at all the case, and that you can live for a very long time on hospice because it provides the support that you need, you know. So I think just educating families so you can tell your friends, you know, what it is and how it works. And you know, I mean, everybody's going to go through it at some point in their lives. We're not going to live forever. And so being prepared for that is something that's very important. I think educating, you know, members of our staff at the hospital and then people in the community so you guys can talk to your friends and family about it and let them know really what it is and what it can provide.
And speaking of, I'll just piggyback off of what she said, as far as our physicians specifically and mid-level providers, Jessica and a representative from hospice meet with every new physician or new provider that comes on staff and gives them an overview of what they do and what it means. And Jessica and I, she's been doing inpatient palliative care since she started, and we're just starting to roll out the outpatient portion of it, which she mentioned. And she and I are actually making visits tomorrow to our primary care providers around Thomasville to give them a little bit more education about what she can provide to the patients here in Thomasville. So
I would also dovetail on that and say that if you ever have the opportunity, go on Amazon and order the book Being Mortal by Dr. Atul Gawande. Dr. Gawande is a surgeon who works at Brigham and Women's Hospital in Boston. He's Stanford undergrad, Harvard Medical School, incredible lecturer, incredible human being. And he wrote this book called Being Mortal, and a documentary was made of that book. And it's basically he and his father, who was also a surgeon, in his end of life, and him trying to save his father, and his father saying, I'm at the stage where I just need comfort, pain comfort. And so we were going to host the movie Being Mortal during the Covey Film Festival, and then we had that Hurricane Michael situation come through. It was the same week. One of the things that I'm working on, we have a donor that's willing to fund it, we've already had discussions with it, is bringing Dr. Atul Gawande here to Thomasville. And the physicians, believe me, that's like bringing Michael Jordan or Brett Favre or LeBron James to hear. Every single one of these doctors looks up to Atul, and he's a very young man. So it's my hope, I can't announce it yet, but it's my hope that in this room, sometime next year, we'll have Dr. Gawande, who, by the way, was just named the CEO of the new healthcare company that Warren Buffett, Jeff Bezos, and Morgan Stanley formed, that includes their 3.8 million workers. So he's a very busy man, but I always say all roads lead to Thomasville. Believe it or not, he's got 3 or 4 different connections to our community. So stay tuned on that. I'm happy because I want our community to hear it, but I'm more excited about our physicians to hear his story as well.
anyone else? Well, thank y'all for coming. Thank you for braving the weather.